Welcome to the first section of emergency medicine. So an approach to a critically ill patient that comes to the ED, first thing you want to do is a rapid primary survey. Then you're going to follow the second sequence of resuscitation. That often it's concurrent with your rapid primary survey. Then you're going to do a detailed secondary survey, then a definitive care. Alright, so rapid primary survey consists of airway, where you are maintaining the airway, and then your C-spine control. B for breathing and ventilation. C for circulation, which is checking the pulse, any hemorrhagic control. D for disability, you're checking on neurological status. E for exposure, you want to do a complete exposure of the patient, you're checking for any fractures, any wound, any abrasion. So that's where you check the patient from head to toes. And then environment where you try to control the patient temperature. So is the patient hypothermia, you want to make sure this patient is normothermia. So it's a continuous reassessment during the secondary survey. So as you go along, you continually reassess back to airway, back to breathing, back to circulation, making sure everything is stabilizing. All right. So if a patient presents with a cardiac arrest, in the case of a patient with cardiac arrest, what we usually use is your your CAB, where you start with your chest compression. Then you give your airway and then breathing. Then in massive trauma situation, usually when the patient has massive blood loss, to try and treat your hypovolemic shock, you're starting with ABC, where you're starting with circulation, you're putting in 2 IV lines up, you're starting with circulation. So in that circumstance, you're starting with CAB as well. So airway, what are we looking at? So the first priority is to secure the airway, and then you make sure that you always assume there's a cervical injury in the airway trauma patient, and you need to immobilize it with a collar. Then you need to assess, is the patient breathing? Can the patient speak? If no, they're obviously having an airway obstruction. You want to listen to any airway obstruction like a stridor, any wheezes, and you can actually change rapidly. So you have to reassess continuously for the stridor, for the airway, any airway obstructions, and then assess if there are any fascials, fracture, edema, burns, because this can collapse the airway very quickly. So you need to try and secure the airway as fast as possible. Now, one of the signs of airway obstructions is agitation. Patient present agitated. They're going to have confusion. They have universal choking sign, where you will see a patient, for example, having the hands on their neck. Respiratory distress. They have increased heart rate, fast breathing. They actually fail to speak. They have stridor. They are looking bluish. Okay. So how are we going to now manage the airway? We have 3 steps. First one is your basic airway management. Second step is having your temporal measures. The third step is your definitive airway management. So first step, which is your basic airway management, is to protect the C-spine and jaw thrust. You're going to do a jaw thrust to open the airway, right? For a patient, so if you're suspecting a C-spine, you want to do a jaw thrust. If you are actually not suspecting any C-spine, you can do a chin lift. And then once the airway is open, what are you going to do? You're going to want to wipe and suction it, and then remove any foreign body that is clear, what you can clearly see with your eyes. You want to take that out, all right? Because that is going to compromise your airway. Then the second step, you want to give the patient some temporal airway measures, just to secure the airway temporarily. So an example of that is going to be your nasopharyngeal airway. So if the patient has a gag reflex that is present, or also known as the patient have been conscious, you're going to use a nasopharyngeal airway. Oropharyngeal airway for a patient that has, if the gag reflex is absent, and then also a laryngeal mask airway that you can also use. Now, if this doesn't work and the patient still desaturates, then you move to the third steps, where you're having a definitive airway management. Here you have an endotracheal tube, so an ETT tube, ETT intubation. All right. So in this, most of the time we use an orotracheal. All right, and an orotracheal route with rapid sequence induction is usually preferred. Okay. And then if that doesn't work, and you have called for help, and then you still cannot get your airways on, then you're going to move to your surgical airway, all right, where you're going to do your cricothyroidotomy. So what are the medication that can actually be given into an ETT? It's going to be mnemonics of navel, N for naloxone, A for atropine, V for Ventolin, E for epinephrine, L for lidocaine. All right. So next, we're talking about contraindication to intubation. If the patient has any supraglottic or glottic pathology, they will actually preclude a successful intubation. That is a contraindication. Next is you, the provider, as the physician. If you do not have full PPE to protect yourself, let's say the patient has COVID-19, let's say the patient has an aerosol generating procedure, so anything that is going to affect you and you don't have proper full PPE, then that is a contraindication to intubation. All right. So when you have a trauma patient, first thing you want to ask yourself, airway management, right? Trauma, is this trauma requiring intubation? Yes. If it's yes, the patient needs it now, then you want to ask yourself, is this patient apneic? If they're apneic, you're going to insert an oral endotracheal tube. If they're actually breathing okay, all right, then you are going to insert an oral endotracheal tube with your rapid sequence induction, right? So if you actually have time, this patient is not that in distress, but you know in the long run you are going to need to intubate this patient, you can send the patient for imaging. And then if they have maybe a C-spine injury, then you're going to do a hyperoptic endotracheal tube or nasal endotracheal tube or rapid sequence induction. All right. Okay, so what are the 4 P's? The 4 P's indication for intubation. The first one is your patent airway. If you don't have a patent airway, you can't intubate. Second is to protect against aspiration, especially if the patient has like a GCS of less than 8. Next is a positive pressure ventilation. And then 4 is for pulmonary toilet, for suctioning, like patient who has cystic fibrosis, for example. So what are the rescue techniques that you can actually use to have a successful intubation? The techniques that you can actually use to help you to successfully intubate are your bougie. So basically it's used like a guide wire. You insert it inside the tube, and then it helps you to easily insert it inside through the larynx. Then you can also use a slide scope. You can also use a lighted stylet. So what happens is that it uses the light through the skin to determine if the ETT is correctly placed. So that's the lighted stylet. You can also use a fiber optic intubation. So it uses a fiber optic cable for indirect visualization. All right. So once you are done with your airway, you move to breathing. When we're talking about breathing, obviously you want to put on your pulse oximetry at the same time. You want to measure your respiratory function. You want to do what is your respiratory rate, what is the saturation. Someone is taking an ABG. You want to check your carbon dioxide levels, and you want to check your AA gradient. All right. So once it's that, then you look, listen, you feel. You actually look for the mental status of the patient. So is the patient has anxiety? Is the patient agitated? Is the patient has loss of consciousness? So that's the mental status. Next, you want to check what is the chest movement. Is it bilateral chest movement? Is it asymmetrical? Respiratory rate and effort. Is the patient having any nasal flaring, increased work of breathing? Are they using their intercostal muscles? Are they using their abdominal muscles? Midline trachea. Is the trachea on the midline, or is it shifted? Any flayed chest? All right. Then you want to listen. You want to auscultate for signs of obstruction, for stridor, for breath sounds. Are we having normal breath sounds? Is the airway. So when you are actually listening to the chest, you're listening to both sides simultaneously. So I'm listening to the upper lobes of the right and then the left, the middle lobe of the right and the left, just like that. So you want to listen for any stridor. You want to have is there symmetry in the airways? Is there any air escaping? Is there any wheeze or crackles? Then you want to feel. You want to check for tracheal shift, any chest wall for crepitus, which will indicate subcutaneous emphysema, or crepitus can also indicate rib fracture. You want to see, is there any sucking chest wound? All right, that could indicate your flayed chest segments. So remember, the noisy breathing is obstructed breathing until proven otherwise. So management of breathing, you want to treat treat likely the underlying cause. So basically treating the underlying cause. For example, giving bronchodilators, epinephrine, diuretics. Once you optimize your oxygenation. So now how do we optimize oxygenation? When a patient comes in, first thing you can give them is your nasal prawns. Nasal prawns does not work. What is higher than nasal prawn is your simple face mask. What is higher than simple face mask is your Venturi mask. Then if it doesn't work, you move to a non-rebreather mask. If that still doesn't work, then you move to from high flow nasal cannula, and then you can move now to CPAP or BiPAP. Okay, so in order of increase FiO2. So basically that means that the amount of oxygen that you can give in with CPAP, right? It's higher compared to the amount of oxygen that you can give a patient with a nasal prawns. And sometimes you don't need to actually go through all this process. You can actually move from giving a mask to CPAP, right? So basically when we're looking at nasal prawns, the amount of oxygens, the FiO2 that can actually be delivered is 25 to 40%. And the amount of oxygen per minute is actually 1 to 6 liter per minute that can actually be given. The face mask, it's actually 5 to 10 liter per minute of oxygen that can be given. A non-rebreather, it's 15 liters per minute. And for a patient giving a CPAP or a BiPAP, you can give this patient up to 100% oxygen. All right. So as you go up, the higher amount of oxygen that you're going to give, you can actually give to the patient. So C, circulation. So what is definition of shock is inadequate organ and tissue perfusion with oxygenated blood. So you're actually unable to actually perfuse. So you have low oxygen blood to actually perfuse your organs like the brain, the kidney, and your extremities. You have the major types of shock. We have 4 major types of shock. First one is hypovolemic shock. Then you have cardiogenic shock, distributive shock, then your obstructive shock. So hypovolemic shock, we're talking about any fluid losses. So when you're losing blood, when, for example, in hemorrhage, in severe burns, you're using fluid, in high output fistula, dehydration due to diarrhea or DKA. Those are your hypovolemic shock. Cardiogenic shock mainly has to do with the heart muscles and the heart valves itself. For example, your myocardial ischemia, your MIs, your dysarrhythmias, maybe your atrial fibrillations, your congestive heart failure, your cardiomyopathies, and then your cardiac valve problem. Okay, there can be those are cardiogenic shock. Then you have distributive shock that are mostly septic, anaphylactic, and the next one is your neurogenic, your spinal cord injury that falls under distributive shock. Obstructive shock, it's your cardiac tamponade, your tension pneumothorax, your pulmonary embolism, your aortic stenosis, your constructive pericarditis. So what are the clinical evaluation? So what are the early signs of shock? So what are the early signs of shock? We're talking about your tachycardia, a narrow pulse pressure, reduced capillary refill, cold extremities. Remember that in neurogenic and septic shock, you are unlikely to have cold extremities. Cold extremities are usually found in hypovolemic, your cardiogenic shock, all right? And reduced central venous pressure. Those are your early signs of shock. Late signs of shock are your hypotension, decreased blood pressure, your altered mental status, reduced urine output. All right, so those are the main signs of late onset of shock. So shock in a trauma patient is hemorrhagic until proven otherwise, right? But if it's a patient who had a heart failure, disease, now they're presenting in shock, but they have no history of trauma or losses of diarrhea or burns, then you can think about your cardiogenic shock. All right. So this is also important, estimation of the degree of hemorrhagic shock. So we have 4 classes. We have class 1, class 2, class 3, and class 4. All right. So class 1, the blood loss is usually lesser than 550 ccc or 550 moles, sorry. And normally you have, everything is usually normal. You're starting from the pulse. Your pulse is normal. Your blood pressure is normal. Respiratory rate is normal. Your capillary refill is normal. Urine output is normal. And usually you give them crystalloid. So these patients, they have lost about they actually lost less than 750 moles or 750 ccc, but then they are okay. The second class, what we have is that they have the blood loss is between 750 to 1500 cc. And then in that case, you start having an increase in your pulse. Remember, those are the first sign of we spoke about the first signs of uh of shock. They start having the first signs of shock, where they can start having a tachycardia. The respiratory rate increases as well. They have tachypnea. They have decreased capillary field, and then urine output is slow, but not so much. And you still give them crystalloids. Okay, so class 2, they only have early signs of shock. Now class 3, blood loss is between 1500 to 2000, which is 2000 moles or cc. And then they will have signs. They are obviously going to have signs of early shock, and then they are also going to have signs of late shock. So what are those? They're going to have increased pulse. So remember, they start having late signs of shock, start presenting late signs of shock if they had a class 3, right? If it's a class 3. So they're going to have an increase pulse, is increase, a decreased blood pressure, an increased heart rate, decreased capillary field, urine output is decreased. In this case, you need to give them crystalloid plus blood. Fourth stage, or the fourth class, they have lost more than 2000 cc or moles, and then you have the pulse is increased to 140, blood pressure is decreased, respiratory rate is increased, capillary field is decreased, urine output, they don't even have a urine output. Then you want to give them crystalloid and blood. Now, what are the causes of shock? Remember, we spoke about the major types of shock. The causes of shock, you're going to use the mnemonic shocked. So S for septic or spinal or neurogenic shock. Next, H for hemorrhagic, O for obstructive, such as tension pneumothorax, cardiac tamponade, pulmonary embolism. C for cardiogenic shock, such as your blunt myocardial injury, your MI, your dysarrhythmia, and then anaphylactic shock. Endocrine, patient had Addison crisis, coma, then drugs as well. So what is the management of hemorrhagic shock? So first, we want to clear the airway. Remember, we always start with, we're going to start with A, B, C, D, E, right? So A, you want to clear the airway and assess your breathing, either first or simultaneously. Then you want to apply direct pressure to any external wound while elevating the extremities. Do not remove any impaled object. So if there's a knife that the patient was stabbed with a knife, you do not remove that. So you don't remove that in the emergency room. You need to actually stabilize the limb, and then this patient needs to be taken to theater. It's only removed, impaled objects are only removed in the OR. You want to start with 2 large bores, IVs, in the brachial or cephalic veins, alright, of each arm. Next, you want to, ideally, you want to do a cross match, but if there's no cross match, you want to use you want to consider an O negative for a woman of childbearing age, and then an O positive for a male. Okay, you want to use, if it's a massive trauma, you want to use massive transfusion protocol, where you're actually using your FFPs, your platelets, and then you can also use your tranexamic acid if there's early bleeding. So next, we're going to talk about disability. We are going to assess level of consciousness using the GCS. Welcome to the second part of emergency medicine. So the second thing we're going to talk about is D for disability. So here we are looking at the level of consciousness using the GCS score. Okay, so the first thing I want to look at is your pupils. You want to assess the quality, the size, the symmetry, and is it reacting to light? Okay, you want to know, is the pupils equal Are they reactive or non-reactive to light? You want to know all of that. Any lateralizing motor deficit that can be present. Now, one of the common side of bleeding is your external, which is, for example, your scalp, then chest, abdomen, which include your peritoneum and your retroperitoneum, your pelvis and long bones, and the GI. So going back to the Glycoscomus scales. So Glycoscomus scale is used in trauma patient with decreased level of consciousness. All right, so it's a trauma patient coming in, decreased level of consciousness, then that's when you actually want to use that. It's a good indicator of the severity of injury and to neurosurgical prognosis. Okay, it's most useful if it's repeated, so you don't want to do that just once. So throughout as you are treating the patient, you want to repeatedly do your GCS score. It's less meaningful for metabolic coma. So it's mostly for patients who've been in trauma, now presenting with low level of consciousness. So a patient with deteriorating GCS needs immediate attention. Okay. So when we're looking at that, we're looking at 3 parts. We're looking at the eyes, we're looking at verbal, and we're looking at motor, and we're making a total out of it. Okay. So if a patient is intubated, then the GCS score would be out of 10 plus T, right? So T means tubed, e.g. no verbal component. So obviously if they're intubated, they don't have any verbal component. So basically you are going to score them out of the eyes opening and the motor response. All right, and plus T. Okay, so when we're looking at the Glycoscomus scale, the first thing we're looking at is your eye opening. So as you go through eye opening, then it's your verbal, then it's your motor, you see that the score increases. So the maximum score you can get for eye opening is 4, for verbal response is 5, for motor response is 6. All right, so for the minimum GCS that a patient can get is 3, and the maximum that a patient can get is 15. Okay, so if GCS is between 13 and 15, you are looking at mild injury. 9 to 12, moderate injury. Lesser than 8, severe injury. And remember, when it's lesser than 8, you need to intubate this patient. So when looking at eye opening, 4, it's going to be spontaneous eye opening. 3 is going to be eye opening to voice. 2 is going to be eye opening to pain. And to 1 is going to be no response. When it comes to verbal response, it's basically you're testing how well can the patient communicate with you. All right. So for 5, is this patient able to communicate fluently? Okay, they're not confused. They're answering question appropriately. So you say, what is your name? What's your date of birth? Where are you from? They're able to give you those answers fluently. Okay, with no confusion. 4 is if they are answering, but they are confused. All right. If maybe they say, what's today's date? They might be confused about that. So they're answering, but they're confused. Then 3, at this point, they're not actually forming sentences. What are they saying? They're saying they're actually making inappropriate words that cannot be understood. Right. So they're not actually forming any sentences. The words that I'm making, they'll be like, you're asking them a question, say, how are you? Then they'll be like, blah, 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 blah. So that will be a 3. And incomprehensive sound will be 2. So you're asking, what is your name? And you would like, what you get, like, So sounds that can actually not be understood. So they're making sound. and then no verbal communication at all is 1. Okay, so very easy. So first 5, they're talking well, they're answering question well. 4, they're answering question but then they're confused. And then 3, they're not answering full sentences, they're just saying inappropriate words. And then 2, they are saying only incomprehensive sound. All right. Then for motor response, starting with 6, they actually obey commands. So you tell them, lift up your hand, they're able to lift up their hand. And then for 5, they're not able to actually obey commands. But then if you tell them, where are you having pain, they're actually able to localize pain. So 6 would be obeys command, 5 would be localized pain, 4 would be withdraw from pain. Right? So they are not responding to you, to any motor, alright? But then when you press, you palpate them, and then you reach that area where they're feeling pain, they kind of withdraw from it. So that is withdraw from pain, which is 4. Then 3 is flexion. The patient will just do abnormal flexion movement of the limbs. And then 2 would be extension, abnormal extension of the limbs. Patient is lying like this, but then you see they're just extending the limb inappropriately. So that would be 2. And 1, no response. Okay. So next, a patient presenting with unilateral dilated, non-reactive pupil. You would think about focal mass lesion, an epidural hematoma, or subdural hematoma. Then E is for exposure. Obviously, when you reach there, you want to expose the patient completely. You want to check the patient from head to toes that there's no injuries that you are actually missing. Then you want to lock roll the patient. Before you lock roll the patient, you first want to do your cervical examination. Then you lock roll the patient. Then you examine the thoracic spine. And then once thoracic spine is examined, you go to lumbar and sacral spine. And then you do your DRE, your digital rectal examination. So digital rectal examination is important because you want to know, are we having any high riding prostate? Is there any palpable bone fracture that you can see? Is there any blood that it comes out from the glove after examinations? So basically just to clear that out. Alright, so you need to eat as well. You need to make sure the patient is kept warm by using blanket or radiant heaters, and then avoid hypothermia. You need to try and give the patient warm fluids and warm blood at all time, and keep providers safe, contaminations. So make sure you wear your PPE at all times. Okay, so we are done with primary survey. Then we're going to focus on resuscitation. Resuscitation is done together with primary survey, right? So attend to ABC. So basically you're trying to manage all life-threatening problems, and then you then put on monitors. Okay, so remember, you work simultaneously. As someone is looking at the airway, somebody is putting the monitors, somebody is inserting the Foley catheter or the NG tube if it's indicated. And then as someone is putting in IV lines, then at the same time they're taking blood for CBC, electrolytes, creatinine, your glucose, your amylase, your toxicology screen, very important, your cross match. So what are actually the contraindication to a Foley catheter? A Foley insertion. Yes, a Foley catheter insertion. Okay, so if a patient has blood on the urethral meatus, all right, you do not insert the Foley catheter. If there's scrotal hematoma, you look at the scrotum, and then you you suspect hematoma, no insertion. And then if there's a high riding prostate, so you do a digital rectal examination, and then the prostate is abnormally high to where it's supposed to, so you do not insert a Foley catheter. Next, what is the contraindication to NG tube for you to put a nasogastric tube in? If a patient has significant mid-phase trauma or they have a basal skull fracture, you do not want to insert an NG tube. So make sure you rule that out first before you decide to do and insert an NG tube. So next, we're quickly going to look at CPR guidelines. So CPR guidelines, they differ in patients, in adults and children and infants. So an adult is over the age of 8, a child is between 1 to 8, and an infant is lesser than 1 year. So first, we're going to look at the airway. Remember, you want to do a jaw thrust if you suspect cervical fracture. If not, it's a chin lift, right? Head tilt, chin lift. Okay. Then you want to give the breath that you want to give us 2 breaths, 1 breath per second. Okay. And you stop once you see chest rise. Okay. And then if there is any severe foreign body airway obstruction, what are you going to do? If the patient is conscious, you're going to do an abdominal thrust for children above 1, and then for children and adult above 1, and then for infant below 1, actually you want to do a back blow or chest compression to remove any foreign body that is obstructing the airway that you cannot actually see. If you can't see it, then you do, if the patient is conscious, put them up, sit them try and stand up, and then you do an abdominal thrust. Compression, what are the landmarks for people over the age of 1? So it's going to be the center of the chest, lower half of the sternum. And then for children lesser than 1 year old, it's just going to be just below the nipple line. Okay. So for compression for adults, which is more than 8 years old, it's going to be 2 hands. You're going to use 2 hands. The heel of one hand will with the heel of the second hand on top of the first one. Same thing for children between 1 to 8. And then 1 to 8 as well, you can also use a one hand technique. And infants lesser than 1 year old, you need to use your 2 fingers, or you need to use your thumbs just below the nipple line. Okay, so what is the compression depth? Is 2 to 2.4 inches in adults over 8 years old, and those below 8 years old, it's 1/3 or half the depth of the chest. So compression rate is going to be 100 to 120 per minute with complete chest recoil between compression. That is for every age group. So for adults above 8 years old, it's going to be 30 compressions to 2 ventilations, and below 8 years old is going to be 15 compression to 2 ventilations. Okay. So immediately as you are starting your ACLS principle, you're going to first call for help, and then now you're trying to find, is the patient responsive? Say, hello sir, is this patient responsive? Not. You're quickly checking your pulse and your respiration at the same time. If no pulse, you're starting your compression. As soon as the defibrillator or help comes along, then you need to assess for any to assess any shockable rhythm. And then once you find the shockable rhythms are your ventricular fibrillation or your ventricular tachycardia. And then once if that is present, then you have to shock this patient before you continue CPR. Okay. So next third step is secondary survey. So once you're done with primary survey, you have to do a full examination. Okay, you might do your, if the patient is stable, that's when you can actually go and do your CT scan or chest x-rays. Okay, but then while you are at it, patient is still unstable, you can do your fast. So basically checking for the heart chambers, the pericardial, any pericardial effusion, looking at free fluid, retroperitoneum. Unfortunately, you cannot assess retroperitoneum fluids with a fast, but you can assess abdominal fluids. So you can look for pelvic fluids, intra-abdominal fluids as well, hepatorenal. Okay, and then you want secondary survey, meaning that you are actually assessing every system. Okay, so this is the time where you want to ask what are the signs and symptom, allergies, any medication the patient is on, any past medical history, what was the last meal, what was the event related to the injury or the illness. So the first thing we're looking at when we examine, so we're going to go into examination now. So remember, we're doing it systematically. The first thing we're going to look at is the head and neck. So your head and neck, you want to inspect for any periorbital bruising. Okay, remember you're also checking for basal skull fracture. What will be the sign? Obviously, you're going to check for any mastoid bruising, any ocular injury. You want to palpate for any facial bone. You want to check the scalp, any bruise, any lacerations, any hematoma. Any bite occlusion test with the tongue compressor if the patient is awake. Alright, then you move to the chest. You want to inspect the chest for equal chest rise. Then is the work of breathing. Is it equal, symmetrical chest rise? Auscultate the chest field. You want to, is there any, is the air entry, the normal breathing sound? Are you hearing wheezes, crackles? So any of that. Then you move to the abdomen. You want to assess for peritonitis. You want to assess, is there any abdominal distension? Is there any focal area of tenderness? And then you want to do your digital rectal examination for selected patient, and then especially patient where you are suspecting any GI bleed, and in trauma if pelvic fracture or frank hematuria is present, then you want to do that. Then you move to your limbs, your musculoskeletal. You want to examine all the extremities for swelling, any deformity, any contusions, any tenderness, and then the range of movement. You want to check for pulses, all right? And then using a Doppler probe, if not palpable, if you cannot palpate the pulses, all right? Then you do your lock roll and palpate your thoracic and your lumbar spine, palpate your iliac crest and the pubis symphysis, and assess pelvic stability. Okay. Then you move to a neurological examination. Here again, you repeat your GCS score. You do your full cranial nerve. Okay. And then you assess your limb strength, assess for sensation of the limb. You're checking for fine motor, especially in a cooperative patient. If the patient is unconscious, then you want to assess the GCS, the breathing pattern, the pupils. Is they reactive to light? And then limb tone, reflexes, posturing. So all of that. And that's what you want to do in your secondary survey. Okay. Then if the patient is stable, all right, you've done your secondary survey, patient is still stable, then you can start now with your imaging. So here you're going to send a patient for For the chest x-ray, this is where you're going to do pelvic x-ray, your EFAS, your so that's why you're going to do your non-contrast CT scan. Okay, so a non-contrast head CT scan is the best imaging modality for intracranial injuries. Okay, all right. So considering the use, welcome to the third series of emergency medicine. So next we're going to talk about ethical consideration. So consent to treatment in adults. Okay. So first thing we're talking about is consent to treatment in adults. So what is the emergency rule? Is that consent is not needed when a patient is at imminent risk from a serious injury, and obtaining consent is either not possible or would increase the risk of the patient. So you always want to assume that most people will want to be safe in an emergency. So you do not need to go ahead to get consent. All right, especially if it's not possible. Especially if you know that you getting consent is going to increase the risk of patient injury. You want to go ahead and treat this patient. All right. But if the patient is capable of giving consent, this patient has been informed and you know they have capacity, right? Then they can actually refuse treatment or part of the treatment, even if this treatment is life-saving. Okay. So this one is for adults. So exception to emergency rule. So treatment cannot be initiated if, right? If a competent patient has previously refused the same or a similar treatment and there is no evidence to suggest the patient wishes has changed. Okay. So if you have maybe treated this patient in the past and then now they're presenting again and they have made it clear, whether in writing or verbally, that they do not want to receive that same care ever again. Okay, and then you have proven evidence that they have not changed this wish, then you do not give them emergency care. So do not an advance in of or maybe if they have an advance directive available, or for example a do not resuscitate order, though this is still controversial. Okay, if they do have a do not resuscitate order and then you know this is of recent, then the emergency rule does not apply. So note, refusal of help in a suicide situation is not an exception. Care must be given. So if a patient presents they had a suicide attempt, you need to give them care as everybody else. So if in doubt, initiate treatment. So if you do not know whether you should initiate a treatment or not, whether they do have a do not resuscitate order, then initiate treatment, and then you can always withdraw treatment at a later time if the wishes are clarified by the family or if they have an advance directive available. Okay, that is for adults. Now for children. For children, you have to treat immediately if the patient is at imminent risk. So parents or guardians have the right to make treatment decision unless the child is mature. So if the child is a mature minor, okay, so depending on the province, then they can make decision for themselves. So if the parent refuses treatment that is considered life-saving or will potentially alter the child's quality of life, you need to act in the best interest of the child. So while you're involving the local child protection service and continuing to engage with the parents and the guardians. All right, so you need to involve, if the patient says no, you cannot give this life-saving intervention to my child. You need to communicate with your local child protection services, and then but then and then still treat the child. Okay, so what a duty to report. So law may vary depending on a province or state. So you need to, you as a physician, you're a duty to report every gunshot wound to the police, any suspected child abuse to the local child protection services, any various communicable disease to the public health, any medical unsuitability to drive, okay, to the Ministry of Transportation, and in risk of substantial harm to others. Okay, so if a patient has said to you that they actually want to kill the neighbor, for example, the first thing you're going to do is that you're going to call the neighbor and report the incident to this neighbor. If you can't get hold of the neighbor, that's when you now call the police. Okay, so Jehovah's Witnesses, capable adults have the right to refuse medical treatment. Now, some patients may decline a whole blood, red blood cell, platelet, and plasma, even if considered life-saving. So always remember that you need to explain to them well the risk of refusing such a care, and then you need to give them alternatives that can actually boost maybe their blood levels or something. Okay, so clarify the use of albumin, immunoglobulin, and hemophilic preparations or other derived products, so that that you can give them to actually substitute if they do not want to receive blood transfusion. Now, parents can refuse care for their child if it's against their belief. Evaluate the risk of treatment refusal and ensure parents are making the informed decision. Now, if life-saving treatment is refused, can act in the child interest, but will need to involve the child protective services. Okay, so you need to involve your child protective services or CAST immediately. Okay, if the parents are saying no, you cannot do blood transfusion on this child. Okay, so you need to document all the discussion you had with this patient. You have to give them alternative offers and also document that as well. You need to give them talk to them about potential risk and then document that as well. Next, we're going to talk about traumatology. Okay, so we are 4.9 million deaths are caused by injury worldwide due to trauma. Okay, so it's a leading cause of death in patients less than the age of 45 years old. Okay, so it causes more death in children and adolescents than all disease combined. Okay, so what are the injuries fall? So the injuries actually fall into two categories. So you have blunt trauma, which is the most common one, and then your penetrating one. Okay, so blunt trauma could be from a motor vehicle accident, could be for pedestrian, automobile impact, could be motorcycle collision, it could be due to fall, it could be due to assault or sport, and penetrating trauma could be due to a gunshot wound, stab, impalement. So consideration for traumatic injury. It's important to actually know the mechanism of injury to anticipate the trauma injury. So always look for an underlying cause. So was the patient on alcohol? Were they medicated? Did they overdose maybe? Were they using any illicit substances? Were they having seizures? Was there any suicide attempt? any medical problem. So always want to use that, look for that. And then always inquire about any loss of consciousness at the scene, what actually happened at the scene. Did they had amnesia, so they can't remember what happened in the scene? That's important. Any vomiting, any headaches, any seizure activity at the scene. Okay. So next we're going to talk about high risk injury. Example of high risk injury are your motor vehicle collision at high speed, so resulting in an ejection from the vehicle, or motorcycle collisions, or vehicle versus pedestrian crashes, or a fall from a height more than 12 feet, which means 3.6, more than 3.6 meters. Those are high risk injury. So mechanism and consideration of trauma injury, you're looking at your motor vehicle collision, your falls, so basically that, and then depending on that associated injury that these patients can have. Obviously, if it's a fall, you need to bear in mind that you can have a spinal injury involved. Can actually involve your thoracic injury, cause thoracic injury, abdominal injury, your extremities injuries. Okay, so next we're going to talk about head trauma. So we're going to move from system to system. First of all, once you need to assess for brain injury. Okay, so first of all, you want to try and have the history, maybe from the police or the paramedics. Okay, so you want to know what happened. Was it a fall? So you can actually anticipate mechanism of injury. So for any head injury, you need to always, when you do your physical examination, always suspect a C-spine injury and rule that out. You need to isolate any penetrating trauma, and then you need to actually do neurological exam, can be performed, and then you want to do your vitals, check for signs of shock, look for Cushing response to increase intracranial pressure, like your bradycardia. So what would be signs of your increase intracranial pressure? It would be your bradycardia, your hypertension, and irregular respiration. So quickly let's look what are the signs of intracranial pressure. Increase intracranial pressure will be number 1, deteriorating level of consciousness. Number 2, deteriorating respiratory pattern. You have your Cushing reflex, which involves increased blood pressure, decreased heart rate, and irregular respiration. Then they can also present with lateralizing central nervous system signs. Example is your cranial nerve palsy, your hemiparesis, your seizure. They can also present with papilledema, which occurs later stage. Also nausea, vomiting, and headaches. So what would be the signs of a patient with a basal skull fracture? So number 1, they're going to have a bruise at the mastoid process just behind the ear, and that is known as the battle sign. Then they can have hemotympanum, so blood coming out from the tympanic membrane. And then your raccoon eyes, okay, which means your periorbital bruising. And then they can also have CSF leaking out from your ears and nose. Okay, so CSF, rhinorrhea or otorrhea. All right. Okay, so you want to check for those signs. Okay, so remember, a patient was suspecting head trauma. You're starting with that. You want to assess for any brain injury. You first want to ask your history. Then you want to do your physical examination from head to toes, checking a cervical spine and mobilizing the cervical spine as well. You're checking for any signs of increase in intracranial pressure, looking at your Cushing response. 2, looking at your Cushing reflex, which is your bradycardia, hypertension, irregular respiration. Then you are doing your level of consciousness to determine the level of injury. So the lower the GCS, the higher the severity of injury. If the GCS is lesser than 8, you want to intubate. Any chance, so you want to intubate this patient, and then GCS between 13 and 15, we're looking at a mild traumatic brain injury, and then moderate will be between 9 to 12 GCS score, and severe between 3 to 8. So at the same time as you're doing the GCS, you're looking at the pupils for the size. You want to check are they responding to light. Then you want to do, is there any lateralizing signs, like you want to check for any motor on sensation, deformity. Then next you will do your investigation. You want to do your CBC electrolytes, glucose toxicology screen always, INR, PTT. You want to obviously do your head CT. And which head CT are you going to do? You're going to do a non-contrast, right, to exclude any intracranial hemorrhage. You want to do your C-spine imaging as well, okay, to rule out any C-spine injuries. So what are the warning signs to severe head injury? So if a patient has a GCS less than 8, think about severe head injury. If they are deteriorating in the GCS, initially they were 15, now they are 10, there's a severity in their head injury. If the pupils are unequal, and if you have lateralizing sign like weakness, poor tone, poor reflexes. Okay, so how would you manage this patient that you're suspecting of head trauma? So the goal in the ER is to actually reduce secondary injury, okay, to the brain. So how can you avoid secondary injury to the brain? By avoiding your hypoxia. So you need to make sure that oxygen saturation is up to date. Avoid ischemia, right? Do you need to give them some fluid? Do you need to give them blood because maybe they have lost so much blood? Are they having any seizure? You want to prevent seizure as well. If they're having currently seizure, you want to treat the seizures. So basically, in general, it says ABC. You need to ensure they're having oxygen delivery to the brain through intubation and prevent hypocapnia. Right? Obviously, low GCS, you need to intubate. Okay? Try and maintain the BP, blood pressure. Right? Sometimes if you have given fluid, you don't want to continuously give fluid because of the complications of that. So you're going to maybe give them vasopressors. Okay. So treat other injury. So, and then make sure you have neurosurgical consultation early. So consult a specialist. And then seizure treatment and prophylaxis. So you can use your phenytoin, your levetiracetam for seizure treatment and prophylaxis. And then if you are actually suspecting increased intracranial pressure, how would you manage that? Because remember what we said, what are we looking at? Then we're going to have your Cushing reflex. Patients actually have increased blood pressure, decreased heart rate, irregular respiration. They've decreased level of consciousness. They are actually can have cranial nerve palsy or hemiparesis. They can present with seizure, nausea, vomiting, headaches. Okay. Fundoscopy, you could actually see your papillary edema. So now, how would you manage this if you're suspecting increased intracranial pressure? Number one, intubate. So We want to do a neuroprotection with rapid sequence induction if where possible. All right, we want to intubate. Number 2, administer fentanyl or lidocaine at least 2 minutes prior to your rapid sequence induction. You want to calm this patient if they're at risk of high airway pressure or agitation. You want to hyperventilate. So hyperventilate 100% oxygen O2 to a PCO2 of 30 to 35. So you want to maintain the PCO2 of 30 to 35. You want to elevate the head above the bed, looking around at least 20 degrees, and then adequate BP to ensure there's a good cerebral perfusion. Then you might give them mannitol 1 gram per kg infused rapidly. It is actually, mannitol is contraindicated in shock and renal failure. So if patient has shock or renal failure, you don't want to give them mannitol. Or you can give them 3 moles per kg of hypertonic, which is 3% saline. Okay? And then remove sequela if possible. So next, disposition, neurosurgical ICU admission for patients who have severe head injury. In a hemodynamically unstable patient with other injuries, prioritize most life-threatening injury and maintain cerebral perfusion. For minor head injury not requiring admission, we can provide a 24-hour observation, right? For this patient. And then if you decide then to send them home, you need to just advise the family, and they need to stay away from sport. If they're presenting with any confusion, amnesia, and then they're not feeling well, then they can come back. So what are the specific injury that we can get from a head trauma? So fracture investigation. Obviously, your investigation, you're going to first do your non-contrast CT scan and a physical exam. When it comes to skull fracture, we have 2 types. We have the Vold fractures, and then you have the basal skull fractures. So Vold fractures usually suspect if there's a non-frontal injury and or if there's a bulgy hematoma. So if there's a non-frontal injury or there's a bulgy hematoma, then you can suspect a Vold fracture. Vold fractures are usually linear. There's 2 types. There's one that is a linear one, non-depressed one, which is the most common, and then there's a depressed one. So the linear non-depressed Vold fractures are usually the most common. Typically occurs on your temporal bone, and usually this is the area where you find the middle meningeal artery. So that's the commonest cause of your epidural hematoma. Okay, then the depressed one is usually open and associated with overlying skull laceration and torn dura. So the skull fracture is disrupted as well as affecting the middle ear as well and the paranasal sinuses. Okay, so you have your Vold fractures can be depressed, and the depressed ones can be either open or closed. So the next type of fracture we'll talk about is your basal skull fracture. We have already spoken about the signs of it. So it typically occurs through the floor of the anterior cranial fossa, longitudinal along. Longitudinal is more common than transverse, and can be radiologically and clinically diagnosed. So it's associated with the battle sign, which the raccoon eyes, your tympanum, your CSF otorrhea or rhinorrhea, through classic signs. So though these classic signs are often delayed. Okay, so that's it for skull fractures. Then on head trauma, you can also have facial fractures. So be aware of open fractures or sinus fractures because they have a risk of infection. Okay, so severe facial fracture may pose risk to airway and profuse bleeding. Okay, so if patient has severe facial fractures, sometimes they may actually require surgical airways. Okay. So next we are going to talk about CT head. So CT head is only required for patients with minor head injury and with any one of the following. So if there's a high risk, if the high risk for neurological intervention, if the GCS is less than 15 at 2 hours after injury, then you need to do CT. If suspected open or depressed skull fracture, then you do CT. Any signs of basal skull fracture, you do CT. Have they been vomiting for more than 2 episodes? Are they more than 65 years old? Then you do your CT scan. Okay. So what are the medium risk is if they had amnesia before the impact, lasting more than 30 minutes. So if you cannot recall events just before the impact, then you want to do a CT. If dangerous mechanism, such as pedestrian struck by motor vehicle collision or occupant, the driver was ejected from the motor vehicle or there's been a fall from more than 3 feet or 5 stairs, then you want to do your CT scan. Okay. So you can also, while looking at head injury, you can also patient can present as well with neuronal injury. So neuronal injury, looking at more at your brain. Okay. So they can have two types: a diffuse neuronal injury, and they can have a focal neuronal injury. So what is a diffuse neuronal injury? So an example of that is your TBI, traumatic brain injury. Okay. So remember, when you're looking at head injury, you have your skull, okay? Then you have your intracranial hemorrhages, meningeal injury, and then you have the brain tissue itself that get injured. So this is what we mean by your neuronal injury. So you can have a diffuse type where the patient present with mild traumatic brain injury. So a mild traumatic brain injury is also known as a concussion. Okay, so the patient had a concussion. Okay. Usually the GCS is between 13 to 15 and patients are usually awake and they may be confused but they're able to communicate and follow commands. So this will be the definition of a patient with a concussion. Okay, so they were involved, they had a head injury, but then now how are they presenting the GCS? It's between 13 and 15. They're actually awake, they're actually able to communicate, able to follow commands, but they're a little bit confused. All right. So there's a transient alteration in the mental status that may involve loss of consciousness. So it's a transient one. It doesn't last for too long. So if they had a level of consciousness, loss of level of consciousness doesn't last for too long. Okay. So what is actually the hallmark? The hallmark of concussion? It's is that number one. So hallmark concussion number one is patient will be confused. You're looking at a GCS about 13 to 15. They will have amnesia. Okay. Which may occur immediately after the trauma or a few minutes after the trauma. So these are the two most symptoms we are looking at. All right. So they're confused. They have amnesia. They can't actually recall what happened immediately after the trauma or few minutes. All right. Then they also have loss of consciousness. If there is loss of consciousness, it's usually less than 30 minutes. And post-traumatic amnesia must be less than 24 hours. Okay. So if they have level of consciousness, it's usually less than 30 minutes. And then if they have any amnesia, this amnesia actually lasts for less than 24 hours. After 24 hours, they're fine. Now, we can, next, it's diffuse axonal injury. So actually, this requires an MRI. Diagnosis rarely made in the ED. So basically what happens for mild is usually the patient will be in coma for 6 to 24 hours, possibly lasting deficit. For moderate, the coma is more than 24 hours, little to no signs of brainstem dysfunction. And severe coma is more than 24 hours, frequent signs of brainstem dysfunction. Okay, so this one is for diffuse axonal injury. So axonal injury, they are going to, so diffuse meaning everywhere, the whole brain, right? And then the last type of neuronal injury is your focal injury, where it's on one side. Only one specific area is affected. And this involves contusions, right? It could be the frontal or the parietal area that is affected, or it could be an intracranial hemorrhage, such as your epidural, your subdural, your intracerebral hemorrhage. So those are your focal type. So let's continue with mild traumatic brain injury. Okay, so TBI result in 1.7 million deaths, hospitalizations, and ED visit each year. Okay, so highest rate is between children between 0 to 4 years old, adolescent between 15 to 19, and elderly patient. Okay. So, what are the clinical features of a patient presenting with a mild traumatic brain injury? They are going to have somatic symptoms, which are headaches, sleep disturbance, nausea and vomiting, blurred vision. They also can have cognitive dysfunction, which means attentional impairment, reduced processing speed, drowsiness, amnesia. They can have emotion and behavioral symptoms such as impulsivity, irritability, depression. And severe symptoms not improving can be a sign of diffuse axonal injury. So what are the causes of mild traumatic brain injury? It could be falls, it could be MVC, your truck struck by an object, assault, spot. So what would you do? You want to do a physical examination, you want to do concussions recognition tool, you want to do an imaging CT scan, MRI if worsening symptoms despite a normal CT scan. And how would you manage a mild traumatic brain injury? You need to have a close observation and follow up this patient For patient at risk of intracranial complication, you need to give them appropriate discharge instructions to the patient and the family. So they need to watch for changes to clinical features or of more severe traumatic brain injury, and if there's any changes to their symptom, they need to return to the ED. Now, you need to arrange immediate CT and neurological consultation if the patient has seizure, any bradycardia, hypotension, a sluggish pupil, or focal deficit. And then hospitalization with normal CT is if the GCS is lesser than 15, they have seizure, they have bleeding, diathesis, or with abnormal CT, then you can actually admit them. Pharmacological management, you manage pain, you manage the depression, you manage the headaches, and follow return to play or return to learn guidelines. Sorry. So actually, most actually recover with minimum treatment. Athletics with previous concussions are at increased risk of cumulative brain injury. So repeat traumatic brain injury can actually lead to life-threatening cerebral edema and permanent impairment. So if they're playing sport, they need to actually stay away from sport for a specific amount of time. So after talking about head injury, we're moving to the spine. So spine and spinal cord trauma. So always assume a cord injury, spinal cord injury with significant fall. So if a fall of more than 12 feet or 3.6 meters, always suspect. If there was a deceleration injury, suspect your spine injury. If there was a blunt trauma to the head or the neck or the back, you always want to suspect. So you always want to, when you suspect, always want to spinal immobilize. So you want to put a cervical collar or a spine board during patient transportation only, and you must be maintained until the spinal injury is ruled out. So make sure you immobilize the spine by using a cervical collar, the spine board during transportation of the patient. If you need to do a CT scan, the patient needs to continuously be on the spine board, and so you remove that until you know that you have ruled out any spinal injury. That's when your cervical collar and stuff are removed. So vertebral injury may be present without a spinal cord injury. Okay, so normal neurological exam does not exclude spinal injury. Right. So let's say if you have a patient that had fall of more than 12 feet, but then the neurological exams are normal. It does not rule out a possibility of spinal cord injury. So you first need to do your imaging. Okay. So the cord may be injured despite a normal C spine X-ray. So remember as well, a normal neurological exam, a normal C spine X-ray does not rule out any spinal injury. Okay, it's not sufficient enough. So a spinal injury can be complete. It could be incomplete transaction. It could be a cold edema. It can be present as a spinal shock as well. So remember, every patient with one or more of the following signs or symptoms should be placed on a C spine collar. Every patient. What are those? Number one, midline tenderness. Palpating the midline, they have tenderness. C spine collar. Neurological symptoms and signs, C spine collar. Significant distracting injuries, C spine collar. because if you have significant distracting injury, they cannot actually tell you if they're having any tenderness or pain. Okay, maybe along the midline, because those other injuries will be distracting them. So you just need to be safe. Uh, any head injury, see spine collar. Patient intoxicated, see spine collar. Dangerous mechanism, see spine collar. History of altered level of consciousness, see spine collar. Right. So CT is the best modality to assess for C-spine injury. Remember, you're doing a neurological exams and chest X-ray. C-spine X-ray is not enough. So you see that CT is actually the best modality to assess C-spine injury. If unavailable and significant trauma is suspected, what do? You protect the C-spine and transfer the patient for definitive imaging. Right, so if you first stabilize the patient, once they're stable, you can now transfer them. Right, so you need a CT scan to rule it out. And obviously, for like every other system, you want to know the mechanism of injury, want to know are they having any neck pain, paralysis, weakness, paresthesia. Okay, you will do your physical exams, your ABC, abdominal, you're checking for ecchymosis, any tenderness, neurological exam, want to do complete neurological exams, including your mental status. Spine, you need to maintain a neutral position. You want to palpate the spine. You want to lock roll, then you palpate the. So remember what we said: palpate the C spine, lock roll, then you palpate T spine, L spine, and you assess your rectal tone. Okay. So when you're palpating the rectal tone, what are you checking for? You're assessing for tenderness, you're assessing for muscle spasm, any bony deformity in the rectum, any step off, any spinal process malalignment. Check for the extremities, check for capillary refills. You suspect any thoracolumbar injury with calcaneal fractures? Alright, so if there is a calcaneal fracture, that you will know that the fall was higher, that actually the mechanism of injury was high. And obviously you want to do your blood, you want to do your CBC's, electrolytes, glucose, coagulation profile, cross match, your toxicology screen, imaging, CT of the spine. So if not available, protect the spine and transfer for definitive imaging. Okay, so what are the indications for imaging? You have unconscious patient, neurological symptoms and findings, deformity that are palpable. When patient is lock rolled, they're presenting also with back pain. Next, bilateral calcaneal fracture. So if they have bilateral calcaneal fracture due to a fall from a height, you need to make sure you do your imaging, okay, because it's a high risk injury. So MRI for soft tissue if appropriate, because if they're having persistent pain, they have paresthesia, they have focal deficit, and you have done CT scan and it's normal, then you will go ahead and do your MRI. Now next, let's talk about Cauda-Equina syndrome. Now Cauda-Equina syndrome can occur with any cord injury below T10 vertebrae. So you are looking at incontinence. Patient presenting is also with anterior thigh pain, quadricep weakness, abdominal, sacral sensation, decreased rectal tone, right? This will be the sign of Cauda-Equina. So patient below can occur with any spinal cord injury below T10 years. Incontinence, anterior thigh pain, quadricep weakness, abdominal sacral sensation, decreased rectal tone. So can you actually clear a C-spine? Okay, so you can actually clear a C-spine injury in a patient. So if the patient is oriented to time, to place, and to event, the patient has no evidence of intoxication. There is no posterior midline cervical tenderness. There is no focal neurological deficit. There is no painful distracting injuries such as long bones and fractures. Able to rotate the neck to 45 degrees in each direction without midline tenderness, then there is no need for imaging. So managing of a cord injury, how would you manage it? So you will immobilize the spine, evaluate your ABC. You want to treat for any neurogenic shock by maintaining the blood pressure above 100. Insert your nasogastric tube once facial fracture excluded to decompress for decompression of your paralytic eyelids. Insert for the catheter only if no concern about urethral injury. Continually reassess high spinal cord injury as edema can travel up the spine. Okay, so if cervical cord lesion, if there is a cervical cord lesion, right, you will need to watch for respiratory insufficiency. So let's say if you have a low cervical transection between C5 to T1, what is it going to do? Going to produce abdominal breathing because the phrenic nerve innervates the diaphragm and is still intact, but you do have loss of innervation of your intercostal and other accessory muscles of breathing. Okay, so if there is a cervical cord injury, you are looking at your respiration. Okay, so cervical injury between C5 to T1, you are looking at patient will have abdominal breathing because the phrenic nerve is not affected. But what do they have lost? They have loss of innervation of your intercostal and other accessory muscles. Now, if you have a high cervical cord injury above C4, C4 going up to the head, right? This may require intubation and ventilation. So soft tissue swelling and hematoma can cause airway compromise, therefore low threshold for intubation, even if patient is otherwise well. So in these patients, if you have a patient C4 and above, then you want to intubate that patient before they deteriorate, okay? Because tissue swelling and hematoma will end up compromising the patient airway. So if the patient is in shock, what are you going to treat them with? So what type of shock can they have? Neurogenic shock, right? You want to maintain the blood pressure. So you would give volume infusion. You might consider your vasopressors, which should be dopamine or adrenaline or noradrenaline or phenylephrine. You want to maintain your normothermia and you want to maintain your glucose levels. Okay? So approach to C-spine imaging. CT of the spine is the screening modality of choice, as we have repeated. Done your CT, it's normal, but the patient still present with paresthesia, the numbness, then you do your MRI. If only C-spine X-ray are available, You need to stabilize the patient and refer this patient. Okay. So, any high risk factor that mandates radiography are what? Number one, a patient more than 65 years old. They had dangerous mechanism, which are number one, or fall from more than 1 meter or 5 stairs. They have an axial load to the head, e.g., they were diving and then they got into an accident. Or they have a motor vehicle collision at high speed, more than 100 kilometers per hour. Or the car rolled over during the incident, or the patient were ejected from the vehicle. They need to have imaging. Or there was a bicycle collision. So these patients need to have imaging. If they have any paresthesia, they feel, for example, tingling sensation, numbness, pins and needles in the extremities, then you want to send them for radiography. Okay. Okay. So basically on the side, uh, this shows actually how your interpretations of a patient C-spine X-ray. Okay, so you can actually check Google to actually help you with that. Okay. So what are the sequelae of a C-spine fracture? So you have, number one, you have an acute phase of your spinal cord injury. So how would the patient uh, uh, present in an acute phase? So it will be either spinal shock or neurogenic shock. So as a patient has had a C-spine injury, how would they present? So initially they present in an acute phase, and the acute phase consists of spinal shock and neurogenic shock. So spinal shock, it will be the absence of all voluntary and reflex activity below the level of injury. So if the injury is at C4, that there will be absence of all voluntary, okay, and reflex activity below that level. There will be decreased reflexes, there will be no sensation, they will have flaccid paralysis below the level of injury, lasting for days to months. Okay. So you can actually do a bulbocavernius reflex. It's actually more reliable than your anal tone, especially if the patient is on coma. So what is just bulbocavernius reflex? So basically is that you're squeezing the glands of the penis or the clitoris, and this should cause your anal sphincter contraction. So if it's absent, then you obviously know that it's so it's better than actually checking the anal tone. Okay. So repeating that, spinal shock, patients are going to have an absence of all their voluntary movements, all their reflexes at the level below that level of injury. Decreased reflexes, they cannot actually feel anything. They are actually having flaccid paralysis, and then this can last for a long time. Next, in an acute phase, they can present with neurogenic shock. So basically, what does this mean? Neurogenic shock means that they have loss of your vasomotor tone. Okay, so the relaxation of the smooth muscles wall. What will happen is that because now they have loss of your vasomotor tone, you're going to have relaxation of the smooth muscles of your blood vessels wall. And then this is going to lead to a massive vasodilation. Okay, so central nervous system tone is gone, right? So if you don't have central nervous system So what is this patient going to be like? So there's no vasoconstriction. Uh, so basically there will be no contractions, proper contractions of your heart, and so on and so forth. So what are you looking at? Patient would then present with hypotension because they're lacking your central nervous system tone. And then they're going to present with bradycardia because there's unopposed parasympathetic nervous system. They are going to have dry skin. They're going to be warm. Uh, so central nervous system, there's a lot of vasodilations that is lost because of the central nervous system that is sympathetic nervous system that are lost, and so there's no shunting of blood from the extremities to the core. Patient will be dry. They'll be warm. So this neurogenic shock actually occurs within 30 minutes of your spinal cord injury at level T6 and above, lasting for up to six weeks. So if patient had an injury from T6 and above, they're likely to present with neurogenic shock, where your sympathetic nervous system is impaired, and this patient has massive vasodilation. All right. So the blood pressure cannot be stabilized. It's going to be low. The pulse is low. Contractility of the heart is low. So how would you manage this patient? You're going to give them airway support, fluid. If they're bradycardia, you can give them atropine. You're going to give them vasopressors for BP support. Your adrenaline, noradrenaline, phenylephrine to actually improve their BP. Okay. So what can happen next? We're going to talk about what can happen in the chronic phase of a patient with spinal cord injury. They can have an autonomic dysreflexia. So an autonomic dysreflexia is a medical emergency. So this occur actually when a patient had a spinal cord injury at a level of T6 and above, right? So basically they will present with signs of a pounding headache, nasal congestion, the feeling of apprehension or anxiety. They're gonna have visual changes. They have a dangerously, what is very important there is they have dangerously increasing their systolic blood pressure and diastolic blood pressure. So number one, what are we looking at? Chronic phase of a patient's spinal cord injury, looking at autonomic dysreflexia. This usually happens at a level of T6 and above. They're presenting with dangerous increase in the blood pressure. They have these headaches, nasal congestion, visual changes. And what are usually the common triggers is if maybe their blood is distended, if they have urinary tract infection, if they have kidney stones, they're causing an obstruction, if they have fecal impaction, constipation, bowel distension. These actually are usually the triggers to autonomic dysreflexia. And how would you treat this patient? Treat the underlying cause. Try and maintain the blood pressure. Monitor the blood pressure and controlling the blood pressure. Treat the underlying cause. If it's bladder distended, put it in a catheter. If it's urinary tract infection, treat the urinary infection. If they have constipation, you want to give them something to help them out, like some laxative to actually help them out. Okay. All right, so now we're done with C-spine. We did head injury, we did C-spine injury. Now we're doing chest injury. So chest trauma. So You have two types. So you have those that are found and managed on the primary survey and those that are found and managed on the secondary survey. Uh, Here we're talking about the cardiac box. So what is the cardiac box? So if your sternal notch, your nipples, the xiphoid process, so any penetrating injury inside these areas, you should have an increased suspicion of cardiac injury. Okay. So what are the life-threatening? So looking at table 7, what are the life-threatening chest injuries found in the primary survey? Number 1, airway obstruction. How on physical examination, what are you going to have? If they have airway obstruction, they're going to be agitated, they're going to have apnea, they will have stridor, they'll have hoarseness, altered mental status. So what do? You want to do your ABC and intubate if you need to. Insert a definitive airway management, okay, early intubation, remove the foreign body, okay, with a Magill forceps prior to intubation. So if you can see the foreign body, remove it, okay, and always be prepared for a surgical airway. Next, tension pneumothorax. Remember, it's a clinical diagnosis, okay, so it's a one-way valve causing accumulation of air in the pleural space. So patient presenting with distended neck veins, asymmetrical chest wall motion. They have tracheal deviation away from the pneumothorax. They have percussion. On percussion, the chest is hyperresonance on the affected side. They have unilateral absence of breath sound on the affected side. All right. Okay. Then obviously they can present with tachycardia, respiratory distress. Okay. So what are you going to do? Remember, it's clinical. You don't need actually investigation for this. You're going to quickly do a needle thoracostomy, large bore needle at the second intercostal mid-clavicular line, right? Or you can do a finger thoracostomy, okay? Then later on, once the air has gushed out, you can now do a definitive management, which is a chest tube. So next you can actually do next that you can see life-threatening chest injury will be an open pneumothorax. So what is this? It's air that is entering the chest from the wound rather than the trachea. So instead of having air moving into the mouth, into the trachea or the nose, you have air that is moving from the wound into the chest cavity. So usually due to gunshot injury, but what you find is that you have unequal chest, unequal breath sounds. This one you can do your ABG. So how would you do this? How would you manage an open pneumothorax? So you do an airtight dressing, sealed on. So basically you are looking at the size of the wound, and then basically you're going to come up with a dressing that is kind of has a four square shape dressing, and then you're going to seal 3 sides of this four shape and leave one side unsealed. Okay, that's basically how you manage an open pneumothorax. So massive hemothorax, so a massive hemothorax, meaning a patient has lost more than, you actually have an accumulation of more than 1,500 cc blood loss in the chest cavity. So this blood will be found in the chest cavity. So remember, you feel dullness to percussion, okay, on the affected side. You have absent breath sound on the affected side, hypotension because this patient has lost a lot of fluids. Then they'll have shock because they've lost fluid. They have distended neck, not distended, but flat neck veins because remember they're hypotensive. Okay. So instead of having the standard neck veins, they're gonna have flat neck veins. So usually you're only able to do a supine X-ray. The entire lung appear opaque as blood sprayed out over the posterior thoracic cavity. So everything goes like white. So what do? You want to restore the blood volume. You want to give them. You need to give them blood transfusion. You crystalloids, and you need to insert a chest tube. Okay, and then you might need to do a thoracotomy if actually the blood found is more than 1500 cc, or the patient is continuously bleeding. So you have to do an open chest surgery known as your thoracotomy. Now, flay chest, what is that? So it's a free floating segment of the chest wall. So you have more than 2 ribs that are broken on 2 sides. One side, then the second side, and it's kind of like free floating. Okay. So usually you have an underlying lung contusion. Okay. And then patient present with paradoxical movement of the flay segment. So basically you have your normal heart chest movement. Okay, then you will see that the flay chest will move opposite to the normal chest movement. So that's what it means. You'll be able to palpate your crepitus of the ribs, and then also you're going to have decreased air entry on the affected side. So you can actually do CT scan, just checking for rib fracture, lung contusions, increase, and you can do a VBG. But normally you don't do much. You just want to make sure the patient pain is managed. Want to make sure that the patient has adequate oxygenation. Okay. So this last one is they can have a cardiac tamponade. This is one of emergency found in primary surveys. Okay, so it's also a clinical diagnosis. Cardiac tamponade is a clinical diagnosis, and usually is due to pericardial fluid accumulation. So the accumulation of fluid in the pericardium, and it's impairing the ventricular function. So pericardial fluid is accumulate. So fluid is accumulating in the pericardium, and then now the ventricles cannot contract. So basically causing cardiac tamponade. So usually it's due to penetrating wound most of the time, and then patient will present with a Beck's triad, which consists of hypotension, the standard vein, neck veins, a muffled heart sound, or the standard heart sound. Okay, they usually have also tachycardia, tachypnea. They have Cosmo signs where they have increased JVP with inspiration. Okay, so you can do check quickly examine it using EFAS, but it says it's a clinical diagnosis. You can also do an echo. Okay, then obviously you want to consult a cardiologist. Okay. So next we are talking about potential life-threatening chest injury found in the secondary surveys. It could be pulmonary contusion. So usually this is due to blunt trauma to the chest, interstitial edema, impairs compliance and gas exchange. So because there were blunt trauma to the chest, this patient's now lungs are affected, and it causes some swelling, and now this impairs your normal chest movement and your gas exchange. So how would you investigate this? You would do a CT scan, and you will see areas of opacifications of the lung within 6 hours of trauma. And the way you manage this is that you want to just maintain adequate ventilation. Make sure you monitor the patient using your ABC, arterial blood gas, your ECG. Then later on, once the patient feels much better, you want to do your chest physiotherapy, positive pressure ventilation if severe. Now, ruptured diaphragm. So usually due to blunt trauma to the chest or the abdomen. It's usually due to high lap belt. So usually to your seat belt in a patient that was involved in an motor vehicle collision. Then chest X-ray. Abnormality, you see an abnormality of the diaphragm, the lower lung field, nasogastric tube placement will be inside the chest. CT scan and endoscopy as well can sometimes be helpful in the diagnosis. Laparoscopy is the definitive diagnosis. Okay, so how would you do? You will manage this patient with laparotomy for diaphragm repair and associated intra-abdominal injuries. Esophageal injury, usually penetrating trauma. They'll have pain out of proportion to the degree of injury. Okay, and then when you do a chest X-ray, you want to do an erect chest X-ray, and the patient will have mediastinal air. But it's not always. You can also do a flexible esophagoscopy. And obviously you want to repair it. If it's present, repair it within 24 hours. An aortic tear, 90% of tear are at the subclavian, just near the ligamentum arteriosum. And then most of patients die at the scene. Okay, so basically patient present with sudden high speed, usually due to a sudden high speed deceleration. So they were involved in a motor vehicle accident, and there was sudden high speed. They were high speed and suddenly they decelerated, or it could be due to a fall or an airplane crash. So they will present with complaints of chest pain. They'll have dyspnea, hoarseness, which is frequently absent, decreased femoral pulses, and differential BP. So basically, when they do blood pressure on your left arm and the right arm, the difference is too much. So base gold standards to actually diagnose us is going to be an aortography, which is a gold standard, but you can also do chest X-ray, CT scan. Management will be a thoracotomy. They have to open the chest and they might need to also treat other injuries. So basically, that's that. So ruptured diaphragm on your right, you have a picture of a patient presenting with an X-ray with you're gonna have a widened mediastinum, which will be a sign of aortic tear. The aortic notch is also distorted, and obviously you're gonna have hemothorax because now this patient is bleeding. So remember, ruptured diaphragm is more often diagnosed on the left side as the liver conceals the right side defect. Okay. So for an aortic tear, what are you gonna see? You have ABC, A, X-ray features of an aortic tear. You're gonna have depressed left main stem. So the main stem bronchus will be depressed on the left side. You have pleural cap. You have a wide mediastinum, which is the most consistent sign. You're going to have hemothorax in distant aortic notch, tracheal deviation to the right, esophagus deviated to the right as well. Okay. So remember, Penetrating injury to the neck. Do not explore any penetrating injury to the neck once you're in the OR. Okay? So anything in the neck, any penetrating injury, you do not take it out. Whether it's a knife, whether it's an object. So if penetrating neck trauma present, number one, don't clamp the structure because it can cause damage to the nerve. No clamp. Don't probe. Don't insert nasal gastric tube. Can lead to bleeding. Don't remove the weapon or the impound object. So yeah. So what if there is a larynx injury? So if maybe the patient had a penetrating injury, how would a patient present with a larynx injury? They'll have a triad, they'll have hoarseness, they're gonna have subcutaneous emphysema, and they're gonna have a palpable fracture. Okay. So basically you want to maintain any larynx, suspecting any larynx injury from a patient who had a penetrating neck injury. Obviously you want to manage the airway because of the edema, and if comfortable can intubate through the defect. Okay, so C-spine may also be injured. Consider mechanism of injury, and then surgery usually is tracheotomy versus repair. So you can also have a trachea or bronchus injury. Patient present with subcutaneous emphysema because of the air that is coming out from the injury site into the soft tissue. And then the Hammond sign, chest X-ray, you're gonna have mediastinum A, persistent pneumothorax, or persistent air leak after chest tube inserted for pneumothorax. So you insert the chest tube, but you still have persistent air leak. So for abdominal trauma, there is two types: blunt trauma that usually causes solid organ injury, like the spleen being the most common injured abdominal organ. Then the liver coming second. For penetrating injury, usually the liver that comes most. So blunt trauma result in two types of hemorrhage. A patient that has been involved in a blunt trauma will present with intraperitoneal and retroperitoneal hemorrhage. So be careful. So if you can't find anything intraperitoneal, make sure to always look retroperitoneal. So always have a high index of suspicious. Always need to have a mechanism of injury and then the history, medical, the drugs they're taking, all of that. Then you do a physical exam, and often unreliable in multiple system trauma. A wide spectrum of presentation. Slow blood loss. So you can actually patient can actually present with slow blood loss, and they cannot actually be immediately apparent. So you can have tachycardia, tachypnea, oliguria, febrile hypotension. So you need to do a series of examination, examine, re-examine. So abdomen, you need to inspect for contusions, for any abrasions, any seatbelt sign, any distension. You want to do your DRE, checking the rectal tone, blood, your bone fragments, and prostate location. Okay, insert your Foley catheter or NG tube if appropriate. Want to do your investigation, your lab result, toxicology, beta ECG, everything. Elevation lead. So imaging of the abdomen. So ultrasound you can use fast, which is quick. So basically the strand is that it identifies the presence of or the absence of so it basically identifies the fast can help you identify the presence or the absence of free fluid in the peritoneal cavity. Okay, and it's also rapid, and it can also examine your pericardium, your pleural cavity. But limitation is that fast, which is the ultrasound, cannot be used to identify specific organ injuries. So if a patient has ascites, then it becomes complicated. Fast can actually give a false positive, and then also it can present a false negative with if the patient has only small amount of blood. False positive negative, as well can be found in retroperitoneal blood and delayed presentation. Also, poor positioning, technical difficult patient. If the patient is obese, then it becomes difficult. Okay, so you can also use an X-ray. Well, for abdominal trauma, you'll be looking for free air under the diaphragm. Okay, and then obviously it doesn't show soft tissue. Okay, CT scan is the most specific test that you can use for abdominal trauma, and in radiations exposure is 20 times more than X-ray. Diagnostic peritoneal lavage really used. So, but it's more sensitive test for intraperitoneal bleed, and then cannot test for retroperitoneal bleed or diaphragmatic rupture, and cannot distinguish at all from trivial bleed. The result can take over an hour, so it takes a lot of time. So when do you need to do laparotomy in a penetrating trauma? So if the patient is in shock, if the patient is shocked but you cannot maintain the shock, you need to take them to the OR. Peritonitis OR, evisceration OR, free air in the abdomen OR, blood in the injured tube, blood in the Foley catheter, or blood on your rectal examination OR. Okay. So imaging. So how would you manage a patient presented with abdominal trauma? Do your ABC, early blood product stabilization, watchful waiting, vessel laparotomy. You need to decide. You need to make sure if hemodynamically unstable or persistently high transfusion required, then laparotomy need to be done. Okay. Hollow organs, organ injury, you need to do a laparotomy. Even if low suspicion of injury, you need to try and admit and observe for at least 24 hours. All right. Next, we're going to talk about genital urinary tract injuries. So etiology normally can be due to blunt trauma, often associated with pelvic fractures. It can involve the upper tracts, which is your kidneys, causing contusions or tears or lacerations. It can affect your lower tract, which is your bladder and your urethra. Then it can also be due to penetrating trauma, causing damage to the kidney, bladder, urethra, and external genitalia. Okay, and It could be also secondary to acceleration deceleration injury, where you have there is a high mortality rate due to laceration and thrombosis of the renal artery and the renal veins and their branches. Okay, it can also be due to iatrogenic, just due to ureter or urethra instrumentations, the use of any instrument. So first of all, you want to ask when a patient presents with genital urinary tract injuries, you want to ask the history, mechanism of action, of injury, sorry. Hematuria, is it microscopic or is it gross hematuria? You want to know, is it blood on the underwear? You want to know any dysuria, any urinary retention present, the history of hypotension. Then you want to go ahead and do a physical examination. You want to do your abdominal examination, check for any flank pain, um, check your for any upper quadrant mass, perineal lacerations. You want to do your digital rectal examination, checking for the sphincter tone, position of the prostate in the presence of any blood. You check the scrotum for any ecchymosis, laceration, testicular disruption, any hematomas. You do your bimanual examination, speculum exams in females, and then extraperitoneal bladder rupture. Uh, if you do have extraperitoneal bladder rupture, you might have pelvic instability, suprapubic tenderness from mess of the urine or extravasated blood. Uh, so you want to check for any urethral injury. And moving to investigation for the urethra, you're going to use a retrograde uretrography. Okay, for the bladder, you can use an ultrasound, you can use CT scan, uretrogram, plus or minus retrograde cystoscopy, or plus or minus cystogram. For the urethra, you're going to use a retrograde uretrogram as well. Okay, for your kidneys, you're going to use a CT scan, which is best if the patient is hemodynamically stable. Okay, so gross hematuria suggests bladder injury. So if a patient presents with gross hematuria, think about bladder injury. Okay, so how would you manage this genital urinary tract injuries? First of all, you want to consult urology. For any minor kidney injuries, you will treat it conservatively with bed rest, hydration, analgesia, and antibiotics. For major injuries, you want to admit this patient, and then you will do conservative management with frequent reassessment. You will do reassess imaging, and then just to treat the underlying cause. Okay. So if for any bladder injury, how are you gonna treat it? If it's extraperitoneal, then if it's a minor rupture of the bladder, then you're gonna put in a Foley catheter for 10 to 14 days. If it's a major rupture, then it might need surgical repair. But if it is an intraperitoneal bladder injury, you're gonna do surgical repair. For the urethra, if it's an anterior injury, it's conservative. So if cannot void, you're gonna insert a Foley or suprapubic cystostomy, and give the patient antibiotic. But if it's a posterior urethral injury, you are going to do a suprapubic cystostomy. So avoid catheterization, and you do surgical repair. Okay. So orthopedics injury, So, how would you describe a description of a fracture? If a patient presenting the fracture, how would you describe a fracture? You're gonna use the mnemonic SoloStat. So you want to check first, note the side. Is it open or closed? What is the length of the structure? What is articular? What is it? Is it is it rotated? Is it translation? Any alignment, angulation? The type of fracture. Okay. So what is the goal of the ED treatment when it comes to orthopedics injuries? So it's to diagnose potential life or slash limb threatening injury, reduce immobilize fractures. You want to reduce and immobilize fractures with cast or splint is appropriate and provide adequate pain relief and arrange for proper follow-up. Okay. So physical exams, you're gonna look, feel, move. So look, inspection. Okay, you look for swelling, erythema, atrophy, deformity, and skin changes. For feel, you're gonna palpate all the joints, bones. For local tenderness, for swelling, for warm, for crepitus, for joint effusion, and any deformity. For move, you're gonna joints affected. You're gonna try and move the joint that are affected, plus those above and those below the injury, and basically you're doing an active range of motion. Is actually preferred to passive one, so you're going to ask the patient to try and move their limb. So you want to also assess your neurovascular status. So you wanted to assess vasculature distal to the injury before and after reduction. So after you reduce the fracture, before you reduce the structure, and after you reduce the structure, you want to make sure the neurovascular status is intact. So what are the life and limb threatening orthopedics injury? So life threatening injuries usually causes blood loss. You'll be your major pelvic fractures, your traumatic amputation, your massive long bone injuries and associated fat emboli syndrome, your vascular injury proximal to the knee or the elbow. The limb threatening injuries usually cause interruption of blood supply. This would be your fracture or dislocation of the ankle because of the popliteal artery found there. Also your crush injuries, compartment syndrome, open fractures, dislocations of the knee or hip, and then fractures above the knee or elbow. Okay, so those will be your limb threatening injuries. So open fracture, it's a communication between the fracture side and the external surface of the skin. Okay, so you have increased risk of osteomyelitis in this patient. So what you want to do is that you want to remove gross debris. You want to irrigate. You want to irrigate maybe normal saline, cover with sterile dressing. So you want to do informal irrigation and debridement, usually often done in the operation room, right? You want to control the bleeding with pressure. So you want to put pressure in to control the bleeding, no clamping. All right. You can put a splint just before so that sustain the limb before the patient's taken to the OR. Then starting with antibiotics as well. So you're gonna start with first generation cephalosporin, aminoglycoside, and tetanus prophylaxis. Okay, so standard of care is to secure definitive surgical management within 6 hours. Time to surgery may vary from case to case. Okay, so that's for an open fracture. So you can also have vascular injury. So what are you gonna do? You're gonna have a surgical consultation. You try and any vascular injury, you want to try and put direct pressure. If there is any external bleed, you want to try and realign the limb and apply longitudinal traction, and then reassess the pulse or do a Doppler just to make sure the vasculature is still intact. So next, when dealing with an open fracture, remember the mnemonic stand. So make sure you splint the fracture. Okay, if you're not gonna let it keep hanging like that, you need to try and stabilize it with a splint. Then you're gonna give this patient tetanus prophylaxis. Then you're gonna give them antibiotics. Then you're gonna make sure the neurovascular status before and after reduction or splinting is intact, and you're gonna do some steroid dressing over just to cover the wound. Okay, so always remember that stand. Now, compartment syndrome. So when the intracompartmental pressure within anatomical area, let's say the forearm or the lower leg, exceed the capillary pressure and perfusion pressure. So basically that's when the patient start having compartment syndrome. So when the intracompartment pressure, okay, let's say maybe in the forearm, right, or the lower leg, is exceeding the capillary perfusion pressure. So meaning that the limb will not be perfused. So eventually this lead to muscles and nerve necrosis. Okay, so what will be, remember, compartment syndrome is a clinical diagnosis, and you need to maintain a high index of suspicion. So what will be the first presentation of patient with a compartment syndrome is that they will have pain out of proportion to the injury. Okay, so they will have pain that is worse with passive stretch. Okay, and then the tense compartment. Okay, so these are actually the first symptom they present with. Then later on they will present with the 6 P's. Okay, so the 6 P's are: number 1 is your pulse discrepancy. They will have pallor, they will have paresthesia, they will have paralysis, pain, especially when refractory to the usual analgesia, and then they will have polar, which is cold, so the limb will feel cold. So you need to look for the P's, but remember, note that those are actually the late signs. Okay. Radial pressure. So note, radial pressure is 120/80 millimoles of mercury, while capillary pressure, perfusion pressure, is 30. So seeing any of the 6P indicate advanced compartment syndrome. So therefore, do not wait for the signs to diagnose and treat compartment syndrome. Okay, because the 6Ps are actually late signs of compartment syndrome. So in an unconscious patient, what are you going to do? You're going to use a Stryker compartment pressure monitor can be used. Okay, because this patient, they will not be able to communicate with you. So you're gonna use a compartment pressure monitor. So how would you then manage this patient? You have to remove any constrictive cast, any constrictive dressing, and then emergent. You need to do a fasciotomy, may be needed. So yes. Next, let's talk about your upper extremity injuries. So upper extremity, first one we're talking about is the anterior shoulder dislocation. Now, what are your vasculature around that? Is your axillary nerve, which is and the lateral aspect of the shoulder, and the muscular cutaneous nerve, which is a causal extension. It's an extensor aspect of the forearm. Okay, so when you order your X-ray, and then on the lateral view you will see the humeral head that it will be anterior to the glenoid. So humeral head will be anterior to the glenoid. So as you can see here, there is a X-ray picture that shows the glenoid being behind, and then the head of the humerus is anterior to that. Then you know that you are dealing with an anterior shoulder dislocation. Okay. So next is your Colles fracture. So what does that entails? So it's a fall on it usually occurs when the patient has a fall on an outstretched hand. So it's a distal, you have a distal radial fracture with a dorsal displacement. Okay, so it's a fracture involving the, so as you can see on this, on figure 6, so basically what you would do for this patient is that you will try and you reduce, immobilize with, then immobilized with a splint, and do an outpatient follow-up with orthopedics, or have immediate orthopedic referral if it's a complicated fracture. Let's say if there's blood neurovascular involvement. But normally you can actually reduce the type of fracture and then immobilize it with a splint. So next is a scaphoid fracture. Okay, so basically the patient will have tenderness in the anatomical snuff box. So pain on the scaphoid tubercle will be felt, and then pain on the axial load of the thumb. Okay, so remember, you might do your x-rays, but you might not see anything. So if the x-ray is negative, it doesn't mean that the chances of having a scaphoid fracture is zero. No. So if you have a negative x-ray, what you will do is you will place in a thumb spica splint, and then repeat x-ray in 1 week. And if you do have CT scan available, bone scan available, then you can send them for bone scan immediately. Okay, so what if, so if you have a positive x-ray, you are going to do a thumb spica splint, and patient come back in 6 to 8 weeks, and you repeat x-ray in 2 weeks. So they will keep it for 6 to 8 weeks, but before that they come back in 2 weeks just to see the progress. So make sure you treat based on clinical suspicion. So even if the x-rays are negative, but then they're having anatomical snuff box pain, they have pain on the scaphoid tubercle, then you're highly suspicious of your scaphoid fracture. So even if the x-rays are negative, you still want to treat this patient. Okay, so why do we need to treat this? Is because they're at risk of avascular necrosis of the scaphoid if actually it's not immobilized. So you need to put your thumb spica splint, and then outpatient orthopedics follow up. So for lower extremities injuries, we're looking at the knee injuries. When we are looking at knee injuries, we need to follow our Ottawa knee rule. Okay. So pelvic injuries, we are looking at ankle and foot in fractures. Then you need to look at your Ottawa ankle and foot rule. Avulsion of the base of the fifth metatarsal. So patient presenting with avulsion of the base of the fifth metatarsal is usually due to an inversion injury. So what you would do is you would do supportive tensor or below knee walking cast. So you're going to insert a below knee walking cast for 3 weeks in a patient who had the base of the fifth metatarsal injury. What about the calcaneal injury? So calcaneal injury is actually associated with fall from a height. Okay. So usually associated with other injuries like involving the ankle, the knee, the hips, the pelvis. So if you have a calcaneal injury, think about this patient had a fall from a height, and then look for other injuries as well. Okay. So what is the is what is your Ottawa knee rule? So basically, what it says is that you're not just gonna do X-ray anyhow. So what happens is that you would do your ankle X-ray. Sorry. So you do ankle radiography series is required only if there is any pain in the malleolar zone of any of these findings. So number one, so if you can see A, if the patient has pain on the posterior edge or tip of the lateral malleola, then you can do your ankle X-ray. Or B, if they have pain on the posterior edge of the tip or the medial malleola, and then if they have inability to bear weight both immediately or in the ED. Okay, so inability to bear weight is that they are unable to do 4 steps. Okay, so now for foot, for the mid-foot it's if they have pain in tenderness, bony tenderness at C. C is the base of the fifth metatarsal, then you do the X-ray. Or if they have bone tenderness at D, which is the navicular bone, or if they have inability to bear weight immediately or after or in the ED. Okay. So how would you manage? Next, we're going to talk about wound management. So the goal of the ED treatment is to identify injuries and stop any active bleeding with direct pressure, and then manage pain, do wound examination and exploration. You need to clean the wound and give antibiotics and tetanus prophylaxis, and then closure and dressing. You want to do proper sterile dressing. So if a patient presents with a contusion is like a bruise, you're gonna how you're gonna manage that? You're gonna use the mnemonics RISE, which means rest. You give them rest. You're gonna apply ice, compression, and elevation of the limb. Okay, so remember that both toxoid and immunoglobulin are safe in pregnancy. Okay, so how would you manage? So you have bruises, then you have abrasions. Just can check on Google how that looks like. Then you have lacerations. So consider every structure deep to the laceration injury until proven otherwise. And then in a hand injury patient, include the following in the history. You want to know what are their occupation, are they right-handed or left-handed? What is the mechanism of injury? What are the other previous history of injury? So once you are looking at an abrasion, a laceration, when you think about a laceration, look at any underlying anatomical. Think about underlying and anatomical structures as well, because it might not just be the laceration that you see. It might have involved other anatomical structures. So you need to examine tendon function actively against resistance, and also examine your neurovascular status distally to the injury. Okay, just to make sure that there are no other anatomical involvement. So you want to clean and explore All right. So when you see a laceration, you want to clean and explore under local anesthesia. So you're look for partial tendon injury. Okay. Looking for partial tendon injury. So don't just start suturing. Before you suture, you need to make sure that be suspicious of any anatomical structure. Right. Try and examine the tendons, the neurovascular. Try and get a neurovascular status distally to that laceration. Try and clean and explore under local anesthesia. Okay. You're looking actually for any partial tendon injury. So you might not be having a complete injury. That's why the limb is still able to move. But they could have a partial tendon injury that may actually need to be repaired. So you want to try and do an X-ray or ultrasound of the wound if a foreign body is suspected. Let's say a shattered glass or uh, and not found. So you want to do an X-ray to see if you can see any objects as well in within the laceration, and not found. If not found when exploring the wound, remember that not all foreign body are radio opaque, and if suspect, then you need to do an intra-articular involvement. If so, how would you manage a laceration? After you have properly examined it, you want to disinfect the skin and use sterile techniques. You want to irrigate with normal saline or tap water. You want to give this patient analgesia anesthesia if possible. Then you use a maximum dose of lidocaine. Lidocaine is 7 milligrams per kg with epinephrine, or 5 milligrams per kg without epinephrine. In children, you can use topical anesthetic such as your LET, which stand for lidocaine, epinephrine, and tetracaine. Okay, so distraction provide. Also, you can in children you can also use distraction uh, provided by either the child life specialist or by the parent. So, and in selected cases, you can actually use short-acting benzodiazepine like midazolam or other agent for sedation and amnesia are usually useful in children as well. Before you start actually with the management of the laceration. So try and secure hemostasis. You need to evacuate any hematomas. So any blood that has coagulated inside the laceration, evacuated all. Then debride non-viable tissue, remove hair and foreign bodies, and you might consider prophylactic antibiotics. So mostly considered in patient where we have animal or human bite or intraoral lesions or punctured wounds to the foot. Okay, so suture unless so you need to suture the wound. So if in cases where you do not need to suture, number one, so do not suture if there's a delay presentation. If the patient presenting after 24 hours, or there's a punctured wound, or there is it's a human bite or animal bite, or there's a crush injury, or there is retained foreign body, you do not want to suture. Okay. So take into account patient and wound factors when considering suture and advise patient when to have suture removed and want to prevent cellulitis and necrotizing fasciitis. Okay, so early wound irrigation and debridement are the most important factors in decreasing infection risk. So make sure you do that. So what are the alternatives to sutures? You can use tissue glue, you can use staples, your steri strips. Next, let's go further into approach to common ED presentations. So here we have differential diagnosis of abdominal pain. The most urgent one. It could be GI involvement. It could be perforated viscous bowel obstruction, ischemic bowel, appendicitis. These are all your differential diagnoses. When we're looking at hepatobiliary, we could be hepatic or splenic injury, pancreatitis, cholangitis, spontaneous bacterial peritonitis. In females, it could be ovarian torsion, ectopic pregnancy, tubal ovarian abscess. In male, it can be testicular torsion. So those are you could have pyelonephritis, could be an MI, aortic dissection, rupture of the aorta. It could be pulmonary embolism, empyema, DKA, sickle cell crisis, toxic, significant trauma. So this actually the emergent causes of abdominal pain. Patient presenting with abdominal pain, what are you going to do? You want to take a history, okay? You want to take your history, physical exam. You want to do the physical examination. You want to review symptoms. Are they having any other symptoms? Are they having any abdominal trauma or surgery prior? In any history, any recent colonoscopy? You want to ask all of that. You want to move to your physical examination. Make sure that you do your abdomen examination, and your abdominal examination is to include your digital rectal exam as well. Okay. And then investigation, you want to do an ABC. Do not delay management and consultation if the patient is unstable. You want to do your labs, investigations, obviously checking in a female presenting with abdominal pain. Remember to always include your BT ECG. So you can do your CBC electrolyte, glucose, your liver enzyme, LFTs, lipase, ECG, troponins, because remember they can present with abdominal pain even though they're having an MI. Okay. So abdominal X-ray if if suspicious of foreign body, or if you're suspicious of small bowel obstruction in a low resource setting. So basically, you can do that. You can do a chest X-ray, an upright chest X-ray, to look for your pneumoperitoneum. So free air under the diaphragm. Okay. So that can tell you any rupture, abdominal rupture. You can also use ultrasound if you are suspecting any gynecological involvement, or any testicular, maybe testicular torsion, for example. You can use ultrasound. CT scans will usually be used for patients who have small bowel obstruction, any abdominal aortic aneurysm, pancreatitis. If you're suspecting kidney stones, appendicitis, diverticulitis, then you use a CT scan. So how would a patient present with a rupture abdominal aortic aneurysm? So they'll present with flank or back pain, number one, pulsatile abdominal mass. So when you palpate the abdomen, you have a mass it's a pulsatile mass, and then hypotension, obviously because they're using blood. Okay, so how would you manage a patient with abdominal pain? It all depends on the presentation. So you sometimes, if there's small bowel obstruction, you want to keep them NPO. You want to insert an IV line. You want to insert an NG tube. Then you want to give them analgesia. Then consider antibiotics and antiemetics. So it all depends how these patients are presenting. Okay, and then consult the patients based on 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 their presentation. So patient presenting with acute pelvic pain. Remember, acute pelvic pain, you always want to do, first thing you want to do is your BTCG for all women of childbearing age, right? It could be a variety of things from ruptured ovarian cyst, which is the most common cause of pelvic pain. Okay, it could be an ovarian abscess, usually a bit rare. Ovarian torsion sometimes. It could be tubal abscess. It could be a uterine fibroid, where a pedunculated fibroid has twisted around itself and causing a torsion. So it could be ectopic pregnancy, spontaneous abortion, certain abortion. It could be endometriosis. It could be dysmenorrhea. So all of that can be causes of acute pelvic pain. So basically, you want to ask them, take a history. You want to ask, are there any other vaginal bleeding, any discharge, dyspareunia, any bowel or bladder symptoms involved, sexual history, any pregnancy. You want to know their menstruation, any fibroid history. Okay. So you want to do your examination, and you assess for cervical motion tenderness. Okay. Also known as the chandelier sign. So a cervical motion tenderness is you if a patient has a suspect PID, pelvic inflammatory disease. Then together you want to do your pelvic abdominal exam as well. So remember, all women of childbearing age want to do a BTCG if they're presenting an acute pelvic pain. Okay. Then you can do the other things, CBC, differentials, glucose. Can do your urine E. So vaginal and cervical swab for cultures and sensitivity is performed if performing a pelvic exams. Or you can do your urine nut. Your urine nut usually for your STI, your gonorrhea, and your chlamydia, especially chlamydia. If no speculum exam is performed. Okay. So you can do your pelvic ultrasound, checking for free fluid, pregnancy, thickening of the endometrium. Can do your Doppler flow studies of your, checking for your ovaries if there's any ovary torsion. So management will be based on the cause. So you want to start with analgesia, determine if admission or consultations is needed with gynecologists. And then for ovarian cyst, unrupture or rupture and hemodynamically stable, you do give them analgesia and follow up. So if a patient present with ovarian cyst, and if it's rupture, if it's unruptured, but they are hemodynamically stable, you will just give them analgesia and follow up. But then if it's rupture and then there's significant hemoperitoneum, they are unstable, they might require surgery. So ovarian torsion, how would you manage it? It's your surgical detorsion or removal of the ovary. So you try and perform detorsion. If not, then you have to remove it. And complicated myeloma, endometriosis, and secondary dysmenorrhea can usually be treated as an outpatient basis, so you can discharge them and then they follow up. So if the patient, you're suspecting a patient has PID, pelvic inflammatory disease, you want to give them broad spectrum antibiotics. So that involves ceftriaxone 1 gram IV, doxycycline 100 milligrams per oz or IV, and metronidazole 500 milligrams per oz or IV. BD. Okay, so recommend low threshold and treat empirically. Okay, so 3 ceftriaxone 1 gram, doxycycline 100 milligrams, and metronidazole 500 milligrams. So what are the next we're going to talk about altered levels of consciousness. So what are the possible cause of coma? Mnemonics. So it's acidosis or alcohol, epilepsy, infection, oxygenation, such as hypoxia, uremia, temperature or trauma, especially head trauma, insulin if it's too little or it's too much, uh, psychogenic or poisoning, structural or space occupying lesions. Those are the causes of coma. So, what is outer level of consciousness? So, outer mental status means it's a collective, non specific term referring to a change in cognition, cognitive function, behavior, and attentiveness. So, it includes like delirium, includes dementia, lethargy. Lethargy is a state of decreased awareness and alertness. The patient may be wakeful, but they don't have their decreased awareness and alertness. Turbo is unresponsiveness to bad arousal. They arouse but they are unresponsive. Coma is a sleep-like state. They're not arousal to any form of consciousness. So they're not conscious. Okay, so glycoscopy scale. So if you have a coma patient, a patient that is lesser than, which has a GCS score lesser than 8, what are the majority causes of this? It could be toxic or metabolic causes. So you first want to check for any metabolic causes or toxic causes. Where you looking for major organ failure, electrolytes, endocrine abnormalities, any toxin, any temperature, any acid disorders, any base disorder, any decrease in oxygen level, lactate, insulin, infection, cardiac or hypercalcemia. You should try and rule that out. So minority causes of coma can be primary central nervous system disease or trauma, where you have on one side it could be due to brainstem. So brainstem affecting the reticular activating system. This could be due to compression, where you have your supra or infratentorial tumor or your subepidural hematoma, or it could be due to a brainstem infarction or hemorrhage. And the other side could be bilateral cerebral hemisphere affecting cognition. So could be a diffuse lesion or diffuse trauma or ischemia. So